We're going to talk about our F tag for F686, quality of care related to treatment and services to prevent and heal pressure ulcers. The intent of this requirement is that resident does not develop pressure ulcers or injuries unless clinically unavoidable, and the facility provides care and services consistent with professional standards of practice to promote the prevention of pressure ulcers and injury development, promote the healing of existing pressure ulcers or injuries, and prevent development of additional pressure ulcers or injuries. The facility must place priority on identifying what each resident's highest practicable well-being is in each of the areas of physical, mental, and psychosocial health. So each resident's care plan must reflect person-centered care, include the resident choices, preferences, goals, needs, and then describe the services and care that is to be furnished to attain or maintain or improve the resident's highest level of well-being. Pressure area can occur whenever pressure has impaired circulation to the tissue. The facility must identify whether the resident is at risk for developing a pressure area on admission and thereafter. So resident specific risk factors and changes in the resident's condition that impact the development of healing of a pressure area. And then we need to implement, monitor, and modify interventions to attempt to stabilize, reduce, or remove underlying risk factors. And if a pressure area is already present, we need to promote treatment to heal it and prevent the development of additional. And the first step of prevention is identifying those who are at risk. Admission evaluations help identify residents at risk of developing pressure areas and residents who already have existing pressure areas. Because a resident at risk can develop a pressure area within hours of the onset of the pressure, the at-risk resident needs to be identified and have interventions implemented promptly to attempt to prevent the pressure area from occurring. In addition, the admission evaluation may identify pre-existing signs that suggest tissue damage has already occurred, and additional tissue loss may occur. For example, if a deep tissue injury is identified on admission, that can lead to the appearance of an unavoidable stage 3 or stage 4. We don't know what's underneath that deep tissue injury. And a stage 1 can progress to an ulcer with eschar or exudate within just days after admission. So some situations that have contributed to tissue damage prior to admission would be like immobility during hospitalization, surgical procedures, prolonged ambulance transport, or waiting to be assisted after things like a fall or a stroke. Examples of risk factors include impaired or decreased mobility and decreased functional ability, comorbid conditions such as end-stage renal disease, thyroid disease, diabetes, medications such as steroids that can affect wound healing, impaired blood flow, so atherosclerosis or arterial insufficiency that can impair the blood flow back up, resident refusal of some aspects of care and treatment, cognitive impairment, exposure of skin to urinary and fecal incontinence, undernutrition, malnutrition, and hydration deficits, the presence of previously healed pressure areas. So the history of any healed pressure area, its treatment origin and stages is important assessment information, since areas of healed stage 3 or 4 are more likely to have recurrent breakdown. Adequate nutrition and hydration are essential for overall function. Nutrition provides vital energy and building blocks for all of the body's structures and processes. Any organ or body system may require additional energy or structural materials for repair, and the skin is the body's largest organ, so it can affect and be affected by other systems. And the skin reflects your overall body function, so skin breakdown may be your first sign that there's another health issue. Both urine and feces contain substances that may irritate the skin and make the skin more susceptible to breakdown and moisture-related skin damage, especially fecal incontinence. There are bile enzymes and bile acids and enzymes in that can hasten skin breakdown and make it happen more quickly. And also moisture can make the skin more susceptible to damage during our shear and friction damage. So based on these assessments, the resident's clinical condition, choices, identified needs, basic care could include, but is not limited to, interventions to redistribute pressure, minimize exposure to moisture, and keep skin clean, provide appropriate pressure redistribution, provide non-irritating surfaces, and maintain or improve nutrition and hydration status where feasible. Any adverse drug reactions related to the resident's drug regimen may worsen risk factors for development or for non-healing of pressure areas. So for example, if there's an increase in their lethargy, increase in their anorexia, so they're not eating well, or an increase in their confusion, those can lead to a higher risk for skin breakdown. So repositioning or relieving constant pressure is a common effective intervention for an individual with a pressure area or someone who is at risk of developing one. Assessment of the skin integrity after pressure has been reduced or redistributed should give the development and implementation of repositioning plans. So if you are repositioning somebody or elevating their heels because there's pressure on their feet, you want to make sure that you're going back and evaluating and making sure that, that is effective for them. And we're not creating pressure in another area. Care plan for a resident at risk of friction or shearing during reposition may require the use of lifting devices for repositioning. Make sure we position the resident, do not position the resident on existing pressure areas because the area is already compromised and can impede tissue healing. So determining the frequency of repositioning takes into consideration the resident's level of acuity and mobility, their general medical condition, overall treatment objectives, their current skin condition, and then their overall comfort. CNAs will inspect skin during baths and while providing care, and will report any concerns to the resident's nurse immediately after the task. Notification can be completed verbal or in writing. I know a lot of the nurses prefer verbal. Little pieces of paper tend to disappear, get misplaced, walk away with a resident. Preventative skin care, so a resident's skin should be kept clean and dry, cleaned at the time of soiling and at routine intervals. Avoid hot water, use mild cleansing agents that minimize irritation and dryness. Rinse thoroughly, pat dry. Try not to use a lot of force or friction, especially over bony prominences. And then minimize environmental factors that can lead to dry skin, such as low humidity or exposure to cold. You want to try to keep linen wrinkle-free, avoid heavy bleach or starch, do not over-pad the bed. So when you reposition or roll a resident, you want to make sure that the linens underneath of them, or even if they're sitting in their chair, are wrinkle-free or as much as can possibly be. Skin should be moisturized daily and PRN. Give special attention to the extremities, but avoid too much pressure on bony prominences. Keep local areas of skin clean, dry, and free from body waste, such as urine, stool, wound drainage, and perspiration. Any absorbent products, such as briefs or underpads, used to contain incontinence must be able to absorb moisture, dry quickly, and wick away from the resident's skin. Use barrier creams or ointments when appropriate. Assist with repositioning per tissue tolerance, and minimize skin injury due to friction and shear through proper repositioning and transfer. Make sure you use socks to protect heels and feet. Heels are extremely vulnerable, must be elevated completely off the bed surface. Utilize pillows, heel float plus boots, or gel boots. Minimize shear forces by lifting the resident during transfers. Do not slide. And use a draw sheet, maxi slide, or transfer board. But when you're done, don't just pull that back out from them. Make sure that you're rolling them properly to avoid those shear and friction injuries. Check for incontinence every 2 hours. Rinse them with a no-rinse, pH balanced personal cleanser. Again, pat the skin dry, don't rub, moisturize, and apply any barrier creams. So nursing assistants, we want you to inspect skin during showers, but we also want you to do skin checks and monitor skin during routine cares. So let's say you're getting somebody up for the day, you notice some redness or excoriation. You're not going to wait till shower day to report that. You're going to report that immediately. Skin conditions that shall be reported include, but are not limited to, redness, bruising, swelling, rashes and hives, blisters, whether they're clear or blood-filled, open tears or open areas, skin tears, ulcers, lesions. Again, pay special attention to bony prominences, pressure points under medical devices, between fingers and toes, and under abdominal folds. When you give showers, make sure you clean between the toes. Dead skin can build up in there and cause some skin integrity issues. Inspect skin while providing care. Inspect skin underneath medical devices at least twice daily. So when we say that, we mean like ostomies. If somebody has an ostomy, you're going to look under that. Make sure that it's not causing some skin integrity issues, like there's perspiring, causing a rash, things like that. Oxygen tubing can cause pressure area on the ears, even with our foam protector, so make sure you're paying close attention to that. Catheter tubes can lead to pressure areas, especially with the balloon port. If your secure device isn't in place properly, that balloon port can push on the skin and create a pressure area. So make sure to utilize positioning devices or pillows to keep body surfaces from rubbing against one another. If you do not have pillows on your floor, you can always call environmental and they can bring you more. Provide and encourage adequate fluid daily, routine repositioning schedule, so every 2 hours, using both side lying and back positions. We want to make sure we're repositioning our residents when they're in bed and out of bed. Utilize maxi slides to reduce shear and force. Avoid positioning the resident directly on any medical devices. When turning to a side lying position, you want to make sure you don't go more than 30 degrees. And ensure heels are floated off the surface of the bed using pillows or other devices, but you want to make sure that you're not putting excess pressure on the Achilles tendon. And then minimize seating time out of bedtime to promote ischial and sacral wound healing. So if you have somebody who has a wound on their bottom, you want to make sure that you're getting them to lay down and offload that pressure as much as possible.